All right, so now we're talking about applying social psychology. I am an experimentalist by nature, and this course, in fact, maybe you guys know about your psych major a little bit, and you're required to take certain courses you're required to take, but then you have to take for the psych major 2 courses that fall into the experimental area and 2 courses which fall into the applied area. And this course, social psychology, falls into the experimental area. Despite that, we're going to talk about applications, okay? I am an experimentalist. That is my diploma. I'm an experimental psychologist. But I'm beginning to get a little bit more appreciation for the applications of psychology. Recently I taught a seminar, Applications of Psychology, and it was fascinating, talking about all the different areas where psychology is used in this world. Hopefully I'll be teaching that course again in the future, I guess. By the time maybe I will. Well, here's where we're going to talk about social psychology. Today we'll talk about social psychology in the clinic. Later we'll talk about social psychology in the courtroom, and then the last one, which is a little bit funky, social psychology in the sustainable future. Suffice it to say, you could talk about social psychology as it applies to sports. Of course you could. Social psychology as it applies to industry. Yeah, sure. Many, many other chapters could be written. These are just the 3 that happen to be here, but many others could be done. All right, clinical psychology. This is not a clinical class. I'm not a clinician. I'm not getting into that stuff. But, I like this slide. There are like 2 different cultures in psychology, 2 different ways of thinking. Here's this question. There are alternative ways of knowing for which the scientific method is irrelevant that should be valued and supported in the practice of clinical psychology. People that call themselves experimental psychologists, look at this, almost 0 agree completely with this, right? Almost none of the experimentalists think that that's a good statement. All right? Almost all the experimentalists think that's a shit statement. Take a look at the clinical psychologists, so. You find that the clinicians tend to be supportive of that type of a statement. All right? As an experimentalist, I agree. That's shit. All right? That's just a garbage statement. I am clearly this person right here. And it's very interesting, though, to see. Everybody knew that there was 2 different types of psychology, but this just lays it out there completely. All right. Yeah, well, there's no correlation between responses on a Rorschach ink blot test and anything. And yet so many clinicians just swear with a Rorschach they can diagnose anything. However, there was this classic study that I really need to get into, Rosen's study. He wanted to know if mental health professionals are able to tell the difference between people who are healthy and who aren't. Okay? Wanted to know if a patient is misdiagnosed, what was going to happen. Okay? So if this patient is given a label, will that label really become that person, or will that person become that label? Wanted to know what it would, wanted to know if psychological diagnoses are in the patient or in the situation or in the observers. Okay, where does it come from? So he took pseudo patients who pretended to be sick to get into a mental health hospital, and then once they gained admittance, then they stopped all symptoms, just completely acted normal. Okay? 5 men, 3 women, 3 psychologists, 1 grad student, a psychiatrist, a homemaker, and a painter. Okay? They called 12 different hospitals on the East Coast, the West Coast, and set up appointments. Then what they did was they said, I hear a voice saying empty, hollow, and thud. Okay? And they were admitted, and everybody except 1 was diagnosed as having schizophrenia. Okay? This is it. Now they're in the hospital. They give 0 more symptoms. Have you seen it? No, I haven't heard anything. I haven't seen anything. Everything looks good to me today. Immediately after being admitted, they stopped any symptoms. The pseudo patients did not know that when they were going to be released, their goal was to get released. Okay. In the end, each person was diagnosed with or discharged with the label of schizophrenia in remission. And the length of hospitalization ranged from 7 days to 52 days, an average of 19 days before they were released. They gave 1 symptom over the phone were admitted and gave 0 symptoms after that. The patients took notes about the hospital and what was going on. And patients would write down a lot. They witnessed physical abuse of the patients. Powerlessness was huge for the patients, right? And what they found, which was really weird, was that the nurses were reporting to the psychiatrists about the note-taking. And this was interpreted by many of these psychiatrists as evidence of paranoid behavior, okay? Paranoid schizophrenia. And so all of a sudden, just the perfectly normal behavior was seen as a symptom, okay? Rosen found that the average contact was about 6.8 minutes a day with any kind of a psychiatrist, resident, physician, anything. 6.8 minutes. So you're putting at a hospital 24 hours a day and you're given less than 7 minutes contact with anybody that might possibly make you better. Lovely. There was a lot of critics. They said, okay, you know what, number one, Rosenhan, it's like, say, for example, a patient comes into the emergency room of a regular hospital and they're vomiting blood. All right? Would you blame the emergency room physicians for doing massive amounts of testing that was, I mean, come on, because that's about the most, by saying I'm hearing voices, that's about the heaviest psychological symptom you could possibly give. So you kind of can't blame them in some way that they were overly cautious, perhaps. So Rosen tried another one. He had staff at one hospital rate patients on a 10-point scale, 1 from very confident, 10 very, not, whatever, about whether or not patients that came in were pseudo-patients. Okay? In over 3 months, 193 patients were admitted. You can read these numbers, right? And of course, there was none. There was no pseudo-patients that tried to gain admittance. Yet at least 19 of them, they swore that there was something going on. Okay? People, wow, that's a funky thing. Anyway, it's a self-fulfilling prophecy all over again, that people become those labels, whatever, okay? But the hospital created much of what was there. So this isn't a surprise. I mean, if a clinician, whether it be a psychiatric clinician or a physician, if they suspect a diagnosis, they're going to ask the patient if they have a symptom. Whenever I go to the doctor, this is terrible. The doctors form an immediate opinion about something very quickly, which isn't bad. I mean, this is a heuristic in action, right? And that's fine, but what then happens is once there's this mental opinion formed, then all of a sudden they're going to start to search for information which confirms what they already believe. All right? They do the, I mean, my daughter's older now, so she's probably not going to be quite so naive, but boy, I can remember this. They would say, does it hurt here? And my daughter would go, yes. It doesn't matter where they poke. You poke her in the bottom of her foot. Does it hurt here? Yes. Well, duh, you're poking me, okay? And so what happened was that by saying, does it hurt when I press on, here? And then they go, yes. You know what? That confirmed exactly what they believed that was going to happen in the first place. So that's what happens with diagnoses, is heuristics give a first opinion, and then the physicians confirm those opinions by seeking out information to confirm it. Most clinicians, we're talking doctors, psychiatrists, physicians, doesn't matter. They believe they're better at diagnosing than statistical data would be. Otherwise, of course, what's the point, right? But it turns out that statistical prediction is almost always better. It turns out that if you ask the clinicians, will this patient be readmitted, yes or no? Or what is the probability that this patient will be readmitted, or something like this? And then you take as a simple measure, how thick is the patient's medical file? And it turns out the thickness of the patient's medical file is a better predictor of readmission than any question you might ask a physician or a clinician. Okay? Of course, insurance companies have known this forever, and that's how they figure out your risks for life insurance and stuff. It's just statistics. Here's a very interesting one. There was a case, a case study, a psychiatric case study, a guy named Joseph Kidd, and they read it in 4 parts. And they read the first part, and then they asked these physicians, clinicians to diagnose, okay? And then they asked them, how accurate do you think you are, okay? And then they read them the second part, and the third part, and the fourth part, and after each one. And so what happened as these clinicians got more and more information, they were convinced that their diagnosis was more and more correct. They were more convinced of their diagnosis. But the truth of the accuracy remained solid. The more information they got, they didn't get better at figuring out the diagnosis, but they believed that they got better. That's troublesome. I am not this kind of guy. You can read this stuff. I don't want to read this stuff. That's your job. Vicious cycle. All right. You guys read this stuff, all right? Shyness is social anxiety. Yeah. I'm not interested in all of this. This is always interesting. Women believe in what they are. I don't know, whatever. Again, I don't feel like it. Okay, this is interesting. What we do and how we respond and how we interact with others can affect our physical health. Type A people are those people that are hard-driven and aggressive. Those are, those people that they get the incorrect change at the grocery store and they scream at the cashier. You know those people? Type B person is a person that gets the incorrect change and either just lets it go or just politely goes to the customer service desk. I'm just saying, I'm in a marriage where there's one type A and one type B. I don't know if you can figure out who is who here, okay? I'm not the type A. So type A people have much more heart disease. They get sick faster. It's all got to do with the stress that they experience. And the stress that they experience is self-created. That's interesting, but you read that one. No. Boring. Boring to me. Maybe fun to you, not to me. Blah, blah, blah. Negative correlation between poverty and health, clearly. Part of it is, of course, the fact that people that are poor can't afford good health care. They tend to have an unhealthy lifestyle, especially in America today. The healthy food costs an amazingly large amount of money. All you got to do is try shopping at Central Market someday, and you'll see, okay? I saw one time, it just shocked me silly. This woman's had like four children, and she's at the grocery store, and then they had a sale on these hot dogs, and they were like 40 cents a pack. And this woman had, I'm not even kidding, just this pile of hot dogs in her cart. It must have been 100 packages of hot dogs. And that family is going to have meat for every day. They get meat every day now. And I mean, that's something they couldn't have. But you know what you get with 100 packages of hot dogs is 100 packages of sodium, okay? Eating healthy in America is incredibly expensive. It really is. Here, last study. This was one, I actually got to meet this guy when I was up at Carnegie Mellon up in Pittsburgh. He was at University of Pittsburgh, UPMC, University of Pittsburgh Medical Center. He came over and gave a talk, a brown bag seminar. And in this study, I forgot his name, but in this study, people come in fact, it was great. They were like volunteers for this study. We'll pay you $1,000 for a week and we'll put you up in a swanky hotel and sweet. Okay, but here's the trick. The day you walk in the door, we're going to take a cold virus on a Q-tip and we're going to jam it up your nose. Up your nose. Oh, shit, okay? And then they watched these people and they watched how many social interactions they had and how sociable they were and stuff. And then what they did was every day they measured how many cold symptoms they had, they were measuring amount of booger drip and all kinds of gross stuff. What they found is those people that were high in sociability, that had many social interactions, caught fewer colds. Those that had fewer social interactions had more colds. There's something about having positive social interactions that creates a healthy immune system. We got to stop there because I'm at 14 and a half minutes. I'll see you back in a bit.